Good afternoon, everyone, and welcome to the PCPI Measure Testing webinar on the overview of measure testing and registries. My name is Crystal Price. I'm the Associate Director of Registry Programs here at the PCPI, and I want to thank you all for taking the time to join us today, given the circumstances. We're excited to cover this information for you. We understand how important it is, so we're going to go ahead and get started and go over a couple of housekeeping items. So this forum is being recorded and all of your lines have been muted. If you have a question, please put it in the chat window and we'll be moderating those and taking questions from there. Feel free to put the questions in the chat menu at any given time so that we can be sure that we get your question before the webinar is over with. During this webinar, we have polls. So you should have received some polling instructions in an email if you signed up as of yesterday. But these are the same polling instructions. You can participate using either a computer or your phone by text message. And I'll give a couple of slides here and we'll do a little bit of an icebreaker here just to demonstrate how the polls work. So with the polls, just go to pollev.com/cprice929 if you're going to do it on your internet browser, or you can send a text message to 22333 and text cprice929 and then text your response. They're pretty easy to use. So this just kind of gives you an overview of what the polls look like. And we'll start off with an icebreaker. If you're stranded on a desert island with one item, what would that be? Seems like we're all kind of stranded on our own personal desert islands this week. Dental floss, that's a good one. I'll give you all about 30 or 40 more seconds to get your answers in. Sunscreen, definitely. No toilet paper? Come on, guys. All right, it looks like you got the hang of the polls here. So we're going to administer a couple of polls that actually pertain to our conversation today. And with that, I'm going to turn it over to Sam Tierney.
Thanks, Crystal. Hi, everyone. I'm Sam Tierney. I'm the Senior Director of Measurement Science at the PCPI. And I'm pleased to introduce my colleagues and your esteemed speakers for this webinar. Heather Tinsley is going to be up first, and she's a project manager with our measure testing team. Heather has a background in measure development and also epidemiology. And then up next, after Heather, will be Deborah. And Deborah Harper is a program manager with our measure testing team. She has a background in social sciences research and also measure implementation. Next slide, please. So I'm not seeing the next slide yet. Hopefully
Bear with me.
Slowly coming. Okay, just making sure. But rather than delay to wait for that, I'll just give you a sense of what we'll be covering today. We'll be covering the goals of measure testing and how things have evolved in the field. Specifically, we'll also talk about testing with electronic data sources, in particular registries. And finally, some common testing methodologies that could be used for registry and QCDR measures. Next slide. So here's where we get to use the poll links to answer questions that are relevant to the topic under discussion today. We just thought it would be helpful to get a good sense of the audience and your why you're here in particular. So we wanted to know what best describes your organization's role. And I'll give you maybe a few more 15, 20 seconds to answer so we can kind of see the mix. Okay, well, things are we've got sort of an even split. I wish we had broken out the other stakeholder groups into other subgroups, but I guess we'll find out more maybe through the conversation. Next slide. We wanted to know if your organization has ever tested measures. The numbers changing a bit, but still a lot more in the yeses than I might have anticipated, which is good news. And maybe some of the content we're presenting today will be more of a review for some of you, or maybe it'll give you some new ideas and thinking about different opportunities and ways to test your measures. Next slide. Will the new requirements, the new testing requirements, affect your measure submission plans for 2021? Assuming they go forward. I know there's still some hope they might not. Okay, so it seems like this, you know, and I know we've certainly heard from our members and stakeholders that this is certainly, you know, a really big concern, and it will have significant impact. And I think this this slide and the results here speak for themselves. Next slide. And how would, I think this is the last question, I believe. How would you describe your knowledge of measure testing? Okay, fairly, I mean, no experts, but certainly more advanced than you know, I was particularly anticipating. So again, maybe this will be a review for some of you, and maybe you can even share experiences from your own testing if we have time at the end. All right, well, thank you so much for indulging us with those questions. I'm going to turn it over now to Heather, who's going to kick things off.
Thank you so much, Sam. Hi, everyone. I'm Heather Tinsley. And so the goals of measure testing are to demonstrate the feasibility and scientific acceptability of a measure. We want to have confidence that measures can reliably capture the data they are intended to capture and ensure that there is no significant difference in the way data are being captured. We also test measures to increase provider confidence and measures as an indicator of quality. And testing is also required for measure inclusion into many national quality reporting programs, and it can demonstrate improved healthcare outcomes through correlations. Next slide, please. In recent years, there has been this transition from measures specified and tested with paper records and administrative claims to measures specified and tested with electronic data sources. In fact, at the 2020 CMS Quality Conference, CMS stated that by 2030, all measures will be digital. The transition to electronic data sources allows for the capture of clinical detail necessary for registry measures and ECQMs. It allows for the integration of data from multiple sources so that we can leverage longitudinal and comprehensive patient information to support quality improvement efforts. Next slide, please. This slide gives you a visual of the granularity of each data source. The EHR data source is at the bottom. It contains the most accurate and granular representation of patient data, which can be aggregated or queried at a finite level and requires precise definitions. There could be challenges with data access, such as tight test site identification, cost, and expertise. At the very top of the graphic, we have claims data. It is the least granular because it's limited to CPT or ICD-10 codes with fixed limits on timing. And further, accuracy is limited to data collection method. In the middle of this data spectrum is registry data. Next slide, please. Clinical registries provide aggregated performance data that can be comprised of fully electronic data or of a combination of data types. These registries are built around precise definitions, and adjustment of a registry measure requires reprogramming within the registry, especially if the registry includes something like natural language processing. Challenges with data access for testing can include cost, measure flow accuracy, and the need for data dictionary alignment. Next slide. Recently, there have been a lot of changes in the testing landscape, with both NQF and CMS changing the way they evaluate and consider measures for endorsement or inclusion into quality reporting programs. In September 2019, NQF released updated testing guidance and their 2019 NQF endorsement criteria. These new changes included an increased emphasis on disparities data for all measures to show importance and performance gap information. Now, all ECQMs, both new and existing, must be tested for reliability and validity at the data element level, as Bonnie testing or score level testing alone are no longer sufficient. Then in November 2019, CMS released the 2020 Quality Payment Program Final Rule, which included the new requirement that all QCDR measures submitted for the 2021 performance period must be fully tested as defined in the MMS blueprint, which follows the NQF evaluation criteria. Essentially, QCDR measures are now being held to the standard of NQF endorsement, regardless of the intent to submit measures for endorsement. For our QCDR stewards, when submitting your measures, we recommend classifying them as registry measures, regardless of how the measure is actually specified, in order to ease the burden of the testing requirements. Next slide, please. On this slide, we have the NQF minimum testing requirements. As you can see, the ECQM measures require a feasibility scorecard and data element level reliability and validity testing, regardless of new or existing status. We will discuss methodologies for testing ECQMs in another webinar later this year. For registry measures, no formal feasibility testing is required. However, the PCPI recommends all stewards and developers conduct at least some level of informal feasibility testing when developing a new measure or when updating the specifications of an existing one. While new registry measures can submit measure score reliability and face validity testing, existing measures are required to complete empirical validity rather than face validity. I should note that within the NQF evaluation criteria guidance, they do state that face validity for an existing measure can be accepted with proper justification. However, it is not spelled out what qualifies as proper justification, and I've personally not heard of NQF granting this testing exemption to an existing measure. If you plan to submit your existing measure to NQF with face validity, I would suggest reaching out to NQF with your justification well in advance of your desired submission date, just in case NQF does come back and tell you that your justification is not sufficient and you'll need to submit empirical testing. I also want to note that for existing measures, if you have already submitted testing and that testing conforms to the current requirements, no new testing is required. Now, you may be wondering how this affects measures that are not intended for submission to NQF endorsement. Well, because CMS has adapted these requirements within the MMS blueprint, you will be required to test your measures as if they were being submitted to NQF. What is not completely clear is how CMS defines new versus existing measures. While it is very clear from NQF that a new measure is one that has never been endorsed and an existing measure is one that has, there's currently no such guidance from CMS as to what qualifies as new versus existing. PCPI has reached out to CMS for clarification on this issue as it pertains to QCDR measures. However, we have not received a response from CMS at this time. Once we do, we will make sure to distribute this information to everyone that we can through social media and through our member list. For now, though, it is safe to assume that if a measure ever has been in the program previously, you will need to submit existing measure testing, and newly developed measures can submit the new measure testing requirements. And so this was a lot of information all at once. I think we have a little bit of time to pause and see if there are any questions. And just to remind you, if you have a question, you can type them into the chat box, which you should be able to see at the top of your screen. And if you aren't able to submit your question right now, we will have time at the end of the presentation for questions, and we will also have an email for you all to reach out to should you have additional questions at the end of the webinar. Okay, I'm not seeing anything coming through the chat. So for time's sake, we will move on, but as I said before, we will have another chance for questions at the end of the presentation, and we will also respond to any emails we get. So feasibility testing is one of the first components of measure testing that stewards and developers may want to consider. As I mentioned on the previous slide, for the purposes of following NQF requirements for measure testing in registry or QCDR measures, it is only required that stewards attest to the extent that the data elements of a measure are electronically available in defined fields. However, you still may want to consider some informal feasibility testing prior to conducting scientific acceptability testing. Feasibility testing allows you to gather qualitative information on the measure that may contribute to further refinement of measure concepts and technical specifications. It allows for the identification of potential challenges to measure implementation. And through feasibility testing, you may be able to formulate strategies for data collection and analysis, as well as develop plans for integration of the measure and anticipate any unintended consequences. Next slide, please. There are several ways in which you can conduct feasibility testing. The most common include feasibility assessments, provider and patient interviews, and focus groups. If conducting testing through a registry which is not owned by your organization, a feasibility assessment can include asking the registry to answer questions regarding their ability to capture data intended for a measure. Provider and patient interviews are where we can sit down with those being impacted by a measure and ask questions regarding feasibility. And finally, focus groups are similar to the clinician and patient interviews, but are conducted in a group setting and allow for collaborative, interactive discussions. And this can be conducted with a technical expert panel or with an expert group outside of those involved with the measure development. Next slide, please. Here are a couple examples of feasibility questions that could be asked of providers and patients. These questions and more can also be considered with your focus groups. So for a provider interview, we may ask, is the data captured during the course of care, and does implementation of the measure or data element negatively impact provider workflow? With a patient interview, if we were interviewing them on a functional status assessment measure, we would ask, at what point during your visit are you asked to complete the functional status assessment? And so feasibility testing can either confirm a measure specifications as being ready for scientific acceptability testing, or it can identify a need to re-specify the measure. If a measure is re-specified as a result of feasibility testing, we suggest retesting the measure for feasibility prior to moving forward. It is suggested that some level of feasibility testing is conducted prior to the more labor-intensive and costly scientific acceptability testing. However, as a reminder, it is not required as part of the NQF criteria used by CMS, so you can choose to forego feasibility testing for your registry or QCDR measures. And so at this time, I will pass the presentation off to my colleague, Deborah, to go through scientific acceptability. Next slide, please.
Thank you, Heather. So scientific acceptability is assessed by using empirical methods to test the extent to which the measure as specified produces consistent or reliable and credible or valid results about the quality of care when implemented. Next slide. We are all familiar with the scramble to gather data and report on reliability and validity. We want to make sure that our measure results are stable and repeatable, and that we are measuring what we are intending to measure. It is important to keep in mind that a measure can be reliable without being valid, but cannot be valid if not reliability. Hence, we want to prove a measure is both reliable and valid. Next slide, please. Reliability ensures that a comparison of measures results for different providers or groups of providers is appropriate. A measure is reliable when it is well defined and precisely specified, allowing it to be implemented consistently within and across organizations. Two commonly used methodologies for assessing reliability are signal-to-noise ratio analysis and data element testing using parallel forms. For this presentation, we will focus on signal-to-noise as it is more commonly used for testing reliability in registry measures. Parallel forms is a type of inter-rater reliability test. It's used at the data element level, and as Heather had mentioned, is a requirement for ECQM. This will be covered in more detail during our ECQM testing webinar in May, so join then if you want to learn more about that as a possibility. Next slide, please. Signal to noise is defined as the proportion of variation in the performance scores due to systematic differences across the measured entities in relation to random error. Signal is the systematic differences and noise is the random error. Signal to noise is measured at the score level while comparing providers. And note that our examples in this presentation specifically mention provider level analysis. However, this methodology would be the same for group level analysis. Signal to noise is calculated as the ratio of provider to provider variance divided by the sum of the provider to provider variance plus the error variance specific to a provider. A reliability of 0 implies that all variability is due to measurement error. A reliability of 1 implies that all variability is attributable to differences in provider performance. For simple measures, a beta binomial model of distribution is used and is defined by the parameters alpha and beta. Next slide. So we are all familiar with this challenge. I think especially registries have experienced a lot of limitations in access to data or implementation of measures, and so this is just hopefully a little humor. Next slide, please. There are three main drivers of reliability: sample size, differences between providers, and measurement error. To get the most robust reliability analysis, we want to consider increasing sample size when possible, including providers that service different demographic groups, and understanding the data sources to minimize measurement error. Additionally, I want to point out that there is not a specific sample size required. It's not uncommon to have a small sample size, like maybe 30 providers in an analysis. You want to make sure you describe your sample and provide a rationale for why you are reporting using the small sample. For example, a measure might be new, and therefore a smaller amount of physicians have begun reporting, or it could be a specialty measure that by nature applies to a smaller population. So the general idea is that as large of a sample as you can get possible, try to go for that within your resources. And if you can't, make sure you have a good justification for why you're using your current sample size. Next slide, please. Reliability is estimated for each unit of analysis, and we report the overall reliability score and describe the reliability distribution. Overall reliability is the average reliability across the providers. Reporting the reliability distribution helps us to understand how consistent reliability is across the providers. For example, is the reliability similar or much lower for providers with smaller numbers of patients? Or is the reliability similar or different for providers in different locations? While there is small amounts of variation in the definitions of medium or high reliability, it's generally accepted that scores in the 70s and 80s are going to indicate a medium to high reliability, and scores in the 90s are indicative of high reliability. And again, there isn't one specific threshold for this either, so you're not going to go to your endorsing body and they're not going to say you have to have 75, but you want to explain what your sample looks like and explain why you think your 70 to 80 to 90% reliability score is good for this measure. Next slide, please. Validity is assessed through the analysis of whether the measure as specified measures what it is intended to. A few common used methodologies are face validity, empirical validity, and data element testing through parallel forms. In this presentation, we're focusing on face validity and empirical validity as these are more commonly used for registry measures. And again, as a reminder, we will talk about parallel forms testing more at our webinar in May, so join that if you are interested. The next slide, please. Face validity is the extent to which an empirical measure appears to reflect that which it is intended to at face value. Data is collected through assessments by experts on the measure topic or in the measure development who did not participate in the actual measure development. Agreement is assessed using a Likert scale to indicate the level of agreement, and the percent agreement is calculated as the number of agree or strongly agree responses over the total eligible responses. We recommend that it's good practice to obtain face validity in addition to empirical validity when you have the resources available to do such, just to provide a more robust reporting of your validity. And also remember that face validity by itself for existing measures is only allowed with justification. It's not commonly done and should be communicated with and agreed upon by the agency that's endorsing your measure before you submit the measure. Next slide, please. Empirical validity is the extent to which the measure quantifies what it claims to be measuring. A correlation analysis of two scores at the provider level is conducted and a reliability score is calculated. For process measures, it is most common to compare scores against related measures that have been validated, often based on similarities in the numerator or denominator. For outcome measures, it's most common to compare the prediction of outcomes across multiple points in time. So I have a couple of examples to talk about comparing denominators and numerators, as this can be kind of confusing to think about. So one situation where we submitted a measure where we were comparing based on similar denominators was for our NQF measure 0384, which is oncology, medical and radiation, pain intensity quantified. We compared this with ASCO's NQF measure 0383, oncology, medical and radiation, plan of care for pain. This selection was due to the similarities in patient population. Both measures focused on patients with a diagnosis of cancer, receiving chemotherapy or radiation therapy. We hypothesized that there exists a positive association between patients in which pain intensity is quantified and those who report having pain with a documented plan of care to address pain. An example of measures that we use the numerators to compare would be for our NQF measure 0070, which is coronary artery disease, beta blocker therapy for prior myocardial infarction or LVEF, left ventricular ejection fraction rate of less than 40%. We compared this with the PQRS measure 118, the coronary artery disease ACE-ARB therapy for CAD with LVEF less than 40%. We hypothesized that there exists a positive association of scores between providers who prescribed beta blocker therapy on patients with coronary artery disease seen within a 12-month period of time and also have a prior myocardial infarction and LVEF less than 40 with those who prescribe beta blocker therapy on patients with a diagnosis of heart failure with LVEF of less than 40 within a 12-month period. So different patient population, both getting the same therapy. Next slide, please. Some factors to consider when assessing validity are exclusions, exceptions, data sources used for calculating measure scores, missing or incorrect data, and differences in the patient mix. Denominator exclusions arise when the clinical action indicated in the numerator is not appropriate for a particular group of patients who otherwise meet the denominator criteria. These are absolute and would be removed from the denominator of a measure in order to determine the eligible population. Denominator exceptions are used to remove a patient from the denominator when the patient does not receive the action required in the numerator and that action would not be appropriate due to a patient-specific reason or reasons. Exceptions are not absolute and are based on clinical judgment or individual patient preferences. The PCPI methodology includes two categories of exceptions, which are medical or patient or non-medical reasons. We have moved away from including exceptions within measures unless clinical experts agree that inclusion of such an exception is paramount to a valid measure. Understanding the data and assessing validity is also important. If you are comparing data from two sources of data, but one has limitations in its data reporting capabilities or has missing data, it may be tough to demonstrate a strong correlation between the measures. You might consider looking for a different data source with more complete data, and if that's not possible, you might choose to report this, but detail the limitations of the analysis and explain why this would still be the best comparison available. When data is available for simple measures, or if it's required for complex measures, it's important to understand the patient mix and how that measure performs across and within different populations. So quite often, we don't have the resource to be able to, for a registry measure to be able to say, here's the demographic mix. But if we have the resources, it's always looked well upon to add that if possible. And if not, that would be something that you're saying, this is our limitation, and you make sure you describe that as well. And I will now pass the presentation back to Sam so she can facilitate a discussion.
Sure. Thank you, Deborah and Heather. I think that was a great overview. So we have a couple questions that we've received so far through the chat. So I'll ask those, and then of course, as we answer, or if you are slow to type, please start to type your questions so we can make sure we get to everything. So the first question is from Bo Fang, and he asks, is there a minimally required number of patients for a given provider to assess the measure's reliability when the measure is defined at the provider level?
Yeah, this
so
is
Deborah, that feels like a question, for you. And I'm sure Heather has too, but you can start maybe.
Yeah, so there is not a specific number, and this is complicated. Obviously, we understand that there's a small amount of patients per provider sometimes. So the way to think about this is, it's okay to include a provider that has 3 patients or 5 patients. However, if all of your providers only have 3 patients or 5 patients, it's going to be hard to actually get a decent reliability score because you're not going to be able to see much variation. So to the best of your ability, you want to have a majority of your providers having maybe 10 or more patients, and having, at least maybe 10 providers so that you have a total sample that's going to get you a decent reliability score. And do include, the providers that have patients less than 10. You don't want to necessarily remove them because that's part of assessing how well your measure is reliable, but you do want to try to have as many. So I know that kind of skirts around a number, but hopefully that answers your question. If you have a follow-up, please type it in, and I'm willing to give some more information. Heather, do you have anything additional?
No, you covered that great. Thank you.
Thanks, Deborah. And I will say, just to add some, color commentary to Deborah's very good answer, we have faced this challenge at NQF before where we used to only report, we would exclude any provider that had less than 10 patients, just, to kind of allow for a consistent, solid number to help with the reliability. And so we didn't have any outliers included. That used to be our method that we followed. However, in recent reviews by NQF, I think their thinking has changed a little bit, and they don't really want you to exclude anyone. They would want you to include, as Deborah mentioned very accurately, they'd want you to include providers who have less than 10 patients, so you're not, I guess, skewing the results too much, and they just want that information reported now. So that's just something from, I guess, being on the front lines of NQF, that they've really gone away from that, and they in fact say that if you did that sort of method, then your specifications would have to specify that you would exclude providers with less than 10 patients, because there's a real emphasis at NQF now to make sure that you're testing the measure according to its specifications. So if you exclude 10 providers with less than 10 patients, your specification should include that level of detail as well. So that is why Deborah's good advice was just to include all the providers, even though you'd want to hope that at least most of them had more than 10 patients in terms of trying to get a reliable statistic. Okay, so we have another question from Amy Beckrich. So the question is for empirical validity. Do you test against an already tested measure, or are you testing simultaneously? And maybe Deborah, you can start with that.
Yes. So that's a simple, straightforward. Yes, you do want to test against an already tested measure. So one that has been in some capacity tested and considered valid, and so that you're going to say my measure is considered valid in comparison to this already validated measure.
Hi, this is Heather, and so I'll just add, when you're collecting your data, you're going to be recollecting data for that tested measure simultaneously. That way you can match up either your NPIs or your TIN numbers when you're comparing the performance results. You clearly can't do empirical validity if you can't align those results across the providers. And so, like Deborah said, you want a measure that's already been tested, but you'll be collecting data for both simultaneously when you query your registries.
Thank you. That was really helpful, Heather and Deborah. Those are all the questions that I see. So I'll give, maybe we can give them another minute or so if you have any other questions to type them in so we can address them. If not, I think we'll probably end early and give you some time back in your day. But I'll still give a couple minutes to ask questions, and then I'm going to turn it over to Crystal to wrap up. Okay, well, actually, I just found another question just popped in. Yay, okay. I was just about to end it. Okay, so Howard asked, this is our second year for submitting registry measures we have not tested previously. If a measure has no related measures that we can find, how do we do empirical validity testing? So I will ask my colleagues to chime in and answer this, and then I have some thoughts myself, but they'll give the more formal testing related answer, and then I'll share some thoughts too. So whichever of you feels most comfortable answering this, please share your thoughts.
Hi, this is Heather. Yeah, it is really difficult. I mean, you want to see if there are any measures that could even be slightly related, or you would expect performance on both to generally be the same for providers that are providing the same quality of care. For measures in the QPP, you may be able to ask CMS for additional data on measures, or ask them if they know of any other measures that you may be able to compare against. and highlighting some of your challenges. I know, especially when you get to the specialty or subspecialty level of measurement, things can get really restricted as far as your selection options for comparison measures. But I would reach out and see if they have any ideas of what to do, or that could be a justification for submitting face validity. If you thoroughly explain, we looked through all these measures, there are no measures that are appropriate to compare to our measure, and therefore we want to do face validity and see if they will grant you that exemption. And Sam, did you have anything?
No, that was actually, you ended with where my mind was going, that could be a good justification for only doing face validity. And I also did want to add, just, and you already touched on this, Heather, how we had asked CMS for clarification of whether they would, how they're defining new versus existing for the purposes of the QCDR testing, especially given that the NQF designations are very clear. And we were pushing for them to sort of adopt the NQF definitions. I mean, NQF, for NQF purposes, a new measure is a measure that's never been submitted before. And an existing measure is a measure that has already been endorsed and is at the point 3 or more years later when it's going through full maintenance. So we were explaining these differences in NQF definitions, and we're hopeful in trying to encourage CMS to adopt a similar definition. In other words, that an existing measure is one that has been in existence for 3 or more years. Now, I don't know, to the extent that CMS will end up defining that or going with really what I would say are the NQF definitions for that, but we are certainly hopeful that they may consider that. And then we have a question from my friend Jensen Chu, who says, 2 questions. When do you think CMS may share their insights between the distinction between new versus existing measures? Good question. We had sent that to them some time ago, probably over a month ago. We didn't hear back right away, but we did hear that they were, like, maybe 2 weeks later, that they were looking into it and would get back to us. So I think that's certainly something as an action item for us from this call that we can follow up and just see if they've considered it further, because it was sort of in their court to get back to us, but we'll certainly follow up. And then for high priority areas deemed by CMS or NQF, based on your recent experiences, have you seen any of the attributes where there's some flexibility around? I assume you mean flexibility around the testing requirements. So I'm not, I would say I haven't necessarily seen them indicate any flexibility or even really introduce this notion of, like, high priority measures may have a different considerations than other measures, at least as it relates to testing. That kind of concept hasn't necessarily been introduced, at least in the conversations I've been a part of. I do know that there are some ongoing efforts to try to get CMS to be more flexible on these testing requirements, and that there's some level of hope associated with that, and that there's a group that's feeling like they're getting some traction in that space. But I don't know. I know when we were on a call with CMS, it seemed pretty clear that they were not going to be making any concessions necessarily, and that they were pretty strict with saying that they put this in the rule, they've been indicating it for some years, and this is what it is, and it's going to go forward. I'm not sure, so maybe, I don't know if anyone on the call has been part of those other efforts where they're trying to get CMS to bend and would be comfortable sharing where that stands. It was our sense that they were kind of unbendable on this point, but I would hope, for the benefit of all of those on the phone, that maybe there is some wiggle room, but we were not really anticipating that just based on what they'd been saying. So I think that takes us to the end of the questions. So I'll give another minute or two to have any more questions, or from anyone who may be aware of the status of those efforts to get CMS to be a little more flexible. And so we'll wait one more minute, and then if not, we'll turn it over to Crystal for wrapping up. I'm not seeing anything. So maybe, Crystal, we'll turn it back over to you. If any questions come up and you want to reach out to us individually or offline, feel free to do that. Or as you're thinking in particular for PCPI members, as you're thinking about your testing plans and you just want some guidance or a quick gut check, please don't hesitate to reach out to us, and we'd be happy to help as much as we can. Thank you. Crystal, over to you.
Thanks, Sam. If you have any other questions, again, feel free to put them in the chat window here, and I'm just going to cover the last couple of things that we have on our agenda. So we do have additional webinars on measure testing. This is a 3-part series. And in April, we'll be looking at a deeper dive into measure testing, specifically looking at case studies of QCDR measures and ECQMs. And then in May, we'll be covering ECQMs in a little bit more detail on the 13th. Other than that, we are also holding our QCDR conference. Many of you probably know this as the AMA QCDR conference. And this year, PCPI is taking it over. We're looking at the state of measurement in registries overall, and we're currently working on an agenda for that. Initially, we had planned to hold this conference in person, but given the circumstances, we are feverishly working on, creating some online solutions, and we're looking at having some small focus groups and then coming together in a larger forum in May to discuss what we've covered in our focus groups. So please stay tuned for that. Make sure that you take a look at the PCPI announcements. That will keep you updated on the happenings for both the webinars and the conference activities. And also want to let you know that the other webinars are live for registration on our website. We'll be posting the video or the recording for this and the slides after the close of this webinar. So look to have that available to you within the next week or so. If there's no other questions, I am going to wrap it up here. If you have any questions about PCPI in general, feel free to contact us at our info inbox. And if you have specific measurement questions, I think you probably know where to find our people, or you can contact them at pcpimeasures@thepcpi.org. Thank you all and have a great day. Bye-bye.